So, welcome everyone to the 20th TIA Centre seminar of the academic year. So, my name's Adam Shepherd, and I'm a postdoc here. And for those of you that are new to our seminars, we invite researchers and leaders in the area of both computational pathology and associated areas to try and discuss their work in these seminars. And as I said already, there's been a lot of interest in learning more about causal ML. So today I'm really delighted to introduce both Professor Stefan Feuerriegel and Valentyn Melnychuk. I'm sorry if I haven't pronounced your names very well there. But Stefan is a full professor at LMU Munich, where Valentyn is a PhD student. Previously, Stefan was an assistant professor at ETH Zurich. In their research, the group develops, implements, and evaluates AI technologies to improve decision-making. The group is particularly interested in understanding the effects of treatment so that treatment decisions can be improved, i.e. with causal ML. The group also brings the causal ML methods into practice with companies and medical professionals. And the title of their talk today is Causal Machine Learning Predicting Treatment Outcomes. And so, yeah, whenever you guys are ready to present, we'd be...
Thank you for the kind introduction. Then let me start first. Why do we care about causal machine learning? Well, as we all know in medicine, we have many problems that are still unsolved. And as we will hopefully introduce you in your talk, we think that causal machine learning is somehow the glue that can bring problems and solutions together in many fields. For example, how do we estimate treatment effects for vulnerable groups? How can we find optimal dosage problems? Here we have a problem which really suffers from data scarcity. Finding optimal dosages is a highly complex problem, simply by the nature of the treatment, which does not fall in the standard randomized controlled trial frameworks. Then other questions are, how can we develop new treatment choices when there is a standard of care absent? Or how can we deal with rare diseases? How can we estimate long-term outcomes from treatments? How can we estimate post-approval efficacy, including like safety and toxicity? So as you see, there are many applications, and all of those that I just mentioned can be fueled by typically real-world data, where we want to better understand treatment effects in order to make more individualized and personalized recommendations of treatments. In the next slides, I would like to motivate you why we need to care about causal machine learning, and I will draw very heavily on real-world data. But by no means, causal machine learning can also be applied to standard experimental data from randomized controlled trials. So you can in that sense, it's a tool that you can use for both real-world data and RCT data. I should also say that causal machine learning has a long tradition in statistics, biostatistics, economics. So those, in many cases, causal machine learning draws up in the same foundations. It draws up in the same assumptions. It just sometimes changes a bit the procedure, and in order to make the estimation strategy maybe more clever or more flexible. In what we're going to present you today, and thank you also for Valentyn for joining me here today, is a joint paper that we recently published with a larger author group at Nature Medicine. It's also titled analogous to the talk, Causal Machine Learning for Predicting Treatment Outcomes. Later, I will also share you a free link where you can access the paper in case you don't have directly access. And of course, a big thanks goes to all of the co-authors that helped you. So in terms of terminology, I would like to start and draw a small line between traditional machine learning, which many of you are already using, to causal machine learning and why we need it. In traditional machine learning, you see it here as a sketch. We have a timeline on the x-axis. We have on the y-axis our patient outcome, for example, survival. We have a patient trajectory here that is drawn, and at some point, the now in time, we want to predict the future patient trajectory in time. And you see that it's maybe degrading, and that is what traditional machine learning is used. It's used for diagnostics purposes. It's used for extensively for risk scoring, like understanding what your 5-year survival is after surgery, what your 30-day readmission risk is after visiting an ICU. But what it is not designed for is to make predictions under decisions or under interventions. And whenever you have a decision or an intervention, action, and I will use those, or treatment, I will use those terms typically as interchangeably, then we change our patient trajectory, we incur a treatment effect. And with causal machine learning, we are interested in making predictions under our interventions. And that's the main difference, is that we are now predicting outcomes of patients under interventions. There's a simple rule of saying, when should I use traditional machine learning? Traditional machine learning should be used as a risk score. It should trigger the alarm when to treat, but guiding treatment choice and how to intervene, that is where you need causal machine learning. There are different reasons why we think causal machine learning can generate new hypotheses. And you see already on this slide, there's a big disclaimer. This is not meant as a replacement to RCTs, but rather as an augmentation. The reason is that we have a growing wealth of data, real-world data, that is now available, also in increasingly better quality. So that we want, like, electronic health records, claims data, disease registries, and we want to leverage this data in order to understand the effectiveness of treatments, as well as the safety and toxicity. So when we talk about real-world data, I sometimes use also the term observational data, which is more the statistical term to it. And what we want to do is then to move from the real-world data to real-world evidence, which based on terminology by the US Food and Drug Administration, refers eventually to the insights that we get about the effectiveness and the safety and toxicity, aka it refers to the analysis of real-world data, with typically the vision of greater personalization in care. And in order to get there, many of the problems refer to estimating treatment effects. Of course, that can be done with classical statistics, by no means, but it can also be promoted by new methodologies. And we think that causal machine learning can be a great help or great asset here. What are potential application scenarios? I'm specifically thinking of settings where we have an absence of a standard of care. For example, in oncology, we are working together with a company in the area of lung cancer, where we want to better understand which treatments work and whether we can develop new treatment guidelines that help. Sometimes we have also new or experimental drugs. If you consider, for example, the outbreak of of the SARS-CoV-2 virus, new vaccines were administered, but we didn't know the real-world efficacy in the beginning. So we sometimes need real-world data in order to understand treatment effectiveness. Sometimes we have also more complex and high-dimension decision problems, like in dosaging problems. And here I really mean finding the exact dosage. There's sometimes, you would say, when you bring dosaging problems into medical practice, you simply compare A and B, simply two dosages, a small and a large, or a dosaging rule. But here we really want to find personalized recommendation in dosages. We have also sometimes settings where randomized controlled trials are unethical, in particular for vulnerable populations like pregnant women. And again, there we want to leverage real-world data in order to understand where treatments are effective. And sometimes we want also to achieve a larger personalization in healthcare. Of course, you would say the gold standard way here is to run very granular, very precisely targeted randomized controlled trials. But that's, of course, sometimes not economically feasible, not scalable to a certain extent. So here, maybe the idea is that maybe in the future we are there that we can use causal machine learning in order to make personalized predictions of which treatments are most effective for a patient. But at the same time, there are challenges when working with real-world data. And the simple example is, for example, whether sunscreen usage is related or is actually causing drowning-related deaths. And if you look into the statistics, you simply get them from online, you would see a strong correlation between the two. And here you see I already used the term correlation because the reason is there is a confounding factor, the weather, the temperature, that drives both factors at the same time. So if you would simply look into the data with like a more traditional model where we don't control for the confounding factor of sunlight, we would simply assume that sunscreen usage actually causes drowning. But that's of course not the case. Instead, we need a more clever approach that is embedded in the causal framework in order to account for the confounding factor of the sun. So here we really need, and that's kind of the challenge, why we're introducing causal, or why we are advocating causal machine learning, because it builds a causal layer on top of machine learning. And I have to say one more disclaimer at this point. Causal machine learning does not imply that the treatment, that the outcomes are necessarily causal, or that causal machine learning only learns cause-effect relationships. Rather, we use the term causal machine learning because we encode mathematical assumptions about the causal graph in the first place when we initiate or instantiate our model. So that's kind of like a slight disclaimer or a warning. So even if you use causal machine learning, you don't necessarily get causal effects, only if you can make it, of course, right. In particular, causal machine learning, or one of the great hopes that we have, is that we can move beyond the average treatment effect. Remember, if you run a randomized controlled trials, you typically compare two groups of patients, those that are treated and your control group. And we only understand that on average, a certain drug is effective. But of course, what we want to do is we want to get much more granular insights into when and for whom treatments are effective. And that's what you see here in the sketch. That's an example. On the x-axis, you see the age. Here on the y-axis, you see the treatment effect. And in this yellow dotted line, you see the average treatment effect that you maybe would get from a randomized controlled trial. But here in blue, we plotted for comparison the individualized treatment effect of each person by different age buckets. And what you see is that maybe this drug here in this example is way less effective than for people of younger age, where it's especially effective for older people. So maybe the practical clinical guideline from understanding the blue curve would be we only treat patients here in this older age buckets, whereas we maybe use no or a different drug for patients in the younger treatment. But that's, of course, an insight that we, by definition, don't get from randomized controlled trials, but rather we need a methodological framework that can translate our data into more granular treatment effects in order to understand the heterogeneity, where treatments are effective and where not. One thing here too, as a disclaimer, that does not mean necessarily that, of course, with RCTs, we can also make comparison of subgroups. But then again, we start using a statistical model in order to make more subgroup specific, or in order to compute subgroup specific treatment effects. And that, of course, you can do with classical statistics. You can also do it with causal machine learning, whereas maybe the latter has a couple of statistical advantages like scalability. So again, causal machine learning, our hope is to make more individualized predictions of where treatments are effective. Also, one more disclaimer, we are calling it individualized. We're not claiming that this is at the individual level of an individual patient, but rather for a specific subgroup, a specific cohort, where you may think that treatments are effective. That could be a specific age cohort. It can be a specific gene biomarker or even digital biomarker that you can use for the to define this individualization. It does not need to be at the individual patient level. Are there any questions at this point in time?
I don't think there's any questions at this stage, but thank you.
Just
Unless anyone else.
question for my
Oh,
own
we got Mr.
clarification. Yeah. So thank you very much. Just I might have not been listening, to be honest. So does it mean that causal methodology, they're not effective in your work with average treatment effect? Or do you think it's also good to have, more causal methods when you're also investigating average treatment effect?
Absolutely. So yes, you can use the causal machine learning methods also with average treatment effects. Of course, if you want to get an average treatment effect from a randomized control trial, you simply need to make the comparison. You don't typically need a proper estimator. But if you would do something like that from real-world data, you do need to compare in real-world data maybe your patient, those that are treated and those that are in your control group. They might be somehow different. Like maybe those that get a specialized treatment are also patients with a more severe status. So normally you would also need to control for it. And maybe you're familiar with the propensity score matching. Those are, of course, very classical methods that work very nicely and that you can use. But if you go a bit further with machine learning, you may get some more advantages like flexibility of the model. It allows you to also incorporate more high-dimensional data. It has a bit more like a principled framework of estimation. So yes, also causal machine learning can be used for average treatment effects, and we will get to that in a bit more. Does that answer your question?
Yeah, thank you. Just clarified for me.
There is also a question in the chat. MD said, I might fail to understand a bit. What is the advantage of causal machine learning over classical subset discovery?
Yeah, of course. So first of all, if you, I mean, there are different ways what you could do. Maybe you're familiar with the target trial emulation, which is a classical framework where you simply make A/B comparison, of course, of different patients. But under this protocol, you do it in a very standardized procedure in order to limit the risk of confounding. But at this moment, when you do that one for very granular subgroups, and you simply compare subgroups, you cannot justify necessarily that the subgroups are equal or similar. Maybe for some reason, female or non-female patients go to or male and female patients go to different practices at certain in certain age buckets. Simply because women are pregnant in a certain, or tend to often pregnant, so they may go to specialized doctors at a certain age bucket. So the moment you start breaking down, you're not really comparing similar patients along any longer. So that's why at some point simply making subgroup specific comparison does not really work and does not allow you to make causal claims. And here, machine learning is one way to really estimate a heterogeneous treatment effect in a very principled way, where you can then also analyze the subgroups with respect to causal effects and not with respect to correlation. That's one thing. So it allows you to make a bit more granular insights into where the treatments are effective. Second, it allows you to handle more high-dimensional data. For example, image data. Of course, we cannot really integrate image data into properly in an RCT. At least we also have to break down the image data. In real-world data, same problem. How do I enter a high-dimensional image into like a simple statistical model like a regression? So again, we have a bit of challenge here. And machine learning may give you a bit more flexibility when you want to, for example, predict also treatment effects with image data. And third, Of course, classical statistics makes also parametric assumptions about the structure of the model. Typically, you have to assume a linear model, and whereas machine learning gives you more flexibility, and it learns also nonlinear function in a principled and data-driven way from your data. So you again have also more flexibility there. Of course, and that's truth to be told, those are many reasons that typically work with more larger data sets, maybe not the smallest RCTs that we have with a couple of dozen of patients, but it's typically designed a bit for larger patient groups. But again, many of the principles and tools that we're presenting here can also be instantiated with linear models. So I think there's like a bigger continuum between classical statistics nowadays and causal machine learning. I don't think they're in boxes or so. I rather would say that this is a huge continuum, maybe more more as an anecdote. Of course, nowadays, many linear models are also rebranded as machine learning or AI. So also here we have of course, a continuum that goes in the same way, but that offers also some new techniques and tools, maybe for subgroup identification, for interpretability. So it gives you a bit more new tools at hand. Any further question?
Oh yeah, we've got a question from this here.
Hi, it's Stefan Feuerriegel here. Can you go back a couple of slides where you showed treatment A versus treatment B? Just as a point of clarification.
Here?
Yeah, on the right-hand side, is it survival as in number of, number of time units, or is it survival probability?
It's survival probability. It's your individualized at the patient level. So it's not like a survival curve.
I see. Okay, I see. Yeah, that's great. Thank you.
Thank you. We also have another question from MD Online. So who said, but aren't we imposing prior in the latter case, e.g. age versus treatment effect? I think that was in relation to the last question.
Prior.
I think
we don't necessarily. No. We don't. I mean, that's exactly the point. We don't. Even though maybe the term prior is here not the right one, but again, exactly we want to understand the treatment effect also for specific subgroups, and there you need proper matching of your patients that they are in each subgroup similar to each other subgroup. And that's very hard to get when you use maybe simply like subgroup analysis. Sometimes propensity score matching then does not scale any longer if you make that too often. And machine learning, because it's designed to generalize, can sometimes be more effective there.
Brilliant. Thank you, Stefan. I don't think we have any more questions in the room.
One hand.
There is one raised hand.
Can I ask a quick question then? So very nice talk. I think it's progressing very nicely. And my name is Fayaz, and I've been working on trying to model image-based survival prediction problems with causal learning for observational studies. And I think the lecture is going to come towards that. But a couple of questions that I have on this is, if I've got an observational study and I apply causal machine learning on it, and then it gives me, let's say, a subset of patients where a certain treatment is working better than the other. So we've got individualized treatment effects. How do we validate those? So we can apply causal machine learning, and then we can get these subgroups. But what would be the ground truth against which we would be comparing? Because we don't have a randomized control trial. So how do you overcome that problem? So that's one question I have on this. The other comment the other point is more like a comment. It's for image-based, I think there's a lot of room of working together for causal machine learning in this domain, and I'll be happy to chat with you later. But the first one is, how do we validate whether our machine learning model or the causal machine learning model is predicting correctly?
Yes. First, send me an email to chat anytime afterwards. So the validation, and now we're coming to what causal machine learning is and why it's challenging. Spoiler, there is no easy way. And it needs to be in subsequent stages always validated if you want properly through RCT data, through proper RCT. Whereas we know that there's also already one drug that was actually approved by the FDA only from real-world data recently, because the evidence was simply too strong. So that's why I'm always saying it. I think this is causal machine learning is especially good for hypothesis generation. But of course, validation is sometimes very challenging. You can run 2-center studies that help you to generate more evidence. So answer is it's not easy. The problem is that causal machine learning or any causal inference, also in classical statistics, any inference of treatment effects from real-world data is always resting on mathematical assumptions that you cannot test. And that's why we need, I think, more like capability building in order also to understand where these methods may work or where they also don't work. So sorry that I don't have a perfect answer. There is no real perfect way for validation eventually.
I completely understand. So it's kind of like, how do we convince people like Vinay Prashad to just use observational studies in down the road? I think that's an uphill battle that the field shares, and I think it would be nice to chat about that as well. But I'll send you an email later. Thank you so much.
I think just a small add-on from me. I think if the benefit of this personalization overweights the cost, then
that's not so easy in medicine, because the FDA is very strict there. But I also seen that they have a new framework for drug design development. So I think in the long term, maybe we start with the easy cases and maybe we generate also more evidence in order to get more trust. Sebastian Schneeweiss from Harvard, for example, he works in epidemiology, and they have reanalyzed many clinical trials with real-world data to see like actually where is real-world data sufficiently precise, and where do we need real-world and where not. So I think he has done a very massive favor for the community to understand where we can use real-world data. But as I said, we can also apply these methods to of course, RCT data. So in order to understand why causal inference is different, people often refer to the Pearl's layer of causation. It's distinguished different levels of inferences that you can make. Level 1 is the association. That's what you do in traditional machine learning. You simply predict what is happening. The layer 2 refers to interventions, and that is about making what-if claims. What happens if I take an aspirin? What happens if I receive a vaccine? So here we make some counterfactual predictions about comparing not only what will happen against like a counterfactual quantity in order then to be able to estimate treatment effects. And in order to introduce that a bit more formally, let me introduce you now two things at the same time. First of all, why causal inference is challenging. And for that one, I will also introduce you a quantity called potential outcome. What you here see in the top figure is an example of our data set that we happen to when making our real-world data set, based on which we want to then maybe predict treatment effects. But as you see in real-world data, we actually never observe. So here you have your patients, we have some covariates about them, we have our treatments, and given our treatment, we observe either the outcome of the patient without treatment or the outcome with treatment. But we never observe both, because we can never observe a patient with both not treated and treated state. So kind of you can think here of like a very unique missing value problem that is very systematically missing data. And that's our input. But nevertheless, we want to then estimate for new patient, maybe our potential outcomes. So those, when I refer to potential outcomes, here I mean my patient outcomes, either under no treatment or under treatment. And when I simply then take the difference, I call this the treatment effect. Why do we say this is the potential outcome instead of like patient outcome? We often use the word potential to signal that we can only observe one of the two quantities at the same time. And one is that the one which we observe is then our factual quantity, and the other one is our counterfactual quantity. But we never observe both at the same time. And so you see, it's very difficult to compute treatment effects due to like the missingness here in the data. And that is actually what we call the fundamental problem of causal inference, because we never observe both. We can only estimate treatment effects under mathematical assumptions. So without mathematical assumptions, we are never able to estimate treatment effects. And that holds true for both causal machine learning, but also causal inference based on classical statistics. So with that started, now we would like to guide you through the causal machine learning workflow. It starts with, of course, defining a research question and collecting data. Then the first block is the problem setup. It's about defining your causal quantity of interest. What type of treatment effect do you want to estimate or predict? It defines about specifying a causal graph. So this is essentially where the causal structure enters into our machine learning problem. Then we have to assess the plausibility of assumptions, because as I just said on the previous slide, we can never predict treatment effects without assumptions. Then we have our actual estimator or treatment effect predictor. Here we will give you a short guidance of different methods for that. And eventually we need to perform checks, especially because several of these assumptions are non-testable, but we can only assess the plausibility of them. So the first step, what you need to choose is what causal quantity of interest do you want to predict. And we arranged them for you here in a little matrix. Here on the left-hand side, you see the average treatment effects. That's what you normally would get out of an RCT. And here on the right-hand side, we have more the individualized treatment effects. And then here in the first column, row, you see the treatment effects. So that is our standard average treatment effect that you would get from an RCT. It would say, like, on average, the treatment A is so and so much better than treatment B. Or paracetamol will have so and so much less side effects than aspirin on average for a patient cohort. Here on the right-hand side, we, however, would try to make very individualized predictions for a small subgroup of patients. And that's what we call normally the conditional average treatment effect, or CATE, because it's conditional on a patient profile X. So that would be, for example, what is the treatment effect for a patient of age 25 and gender like woman, for example. So we're trying to get into smaller subgroups and make more granularized predictions of treatment effects here. Another thing that you could be interested in, you may not only be interested in the treatment effect, whether one is better than the other or by how much, but maybe in oncology, for example, you would be interested in directly in the outcomes of the patients. So, for example, you develop a decision support tool for precision oncology. You may want to tell the patient, well, not only is immune therapy better for you than chemotherapy by so and so much, but maybe you want to say, like, well, if you take immune therapy, this is like your life expectancy, and this is your chance of side effects. But if you get chemotherapy, this is your life expectancy, and these are your side effects. So what you see is you have different types of quantities that you could estimate. Again, average treatment effect, ATE, is what we typically get out of the RCT. For everything else, going to Kate, we need to make mathematical assumptions, even in randomized controlled trials, in order to make more subgroup-specific predictions. Potential outcomes, rule of thumb, I think those are most relevant for clinical decision support systems. Now you would, of course, typically say, well, Stefan, shouldn't we always go for the most granular quantity? Sure thing, that's possible. But the problem is the more granular you choose your quantity, the more challenging it is for the machine learning models, and that hampers precision. So our recommendation is, of course, go for the most aggregated quantity that you can have, unless you need more granularity for your specific application. So, and that's where I am handing over to Valentyn.
Right. Yeah. Thank you for introduction. Should I first talk about assumptions, or should I go?
You can go through the from here. Given the time, I think that would work.
Yeah. Yeah. So just And we need if you, I can say a couple of words about previous slide.
Yeah, we need to also make a break for questions, maybe now, quickly. One or two, and then
I continue.
Fantastic. Thank you, Stefan. So have we got any more questions from anyone in the group for now?
Just a quick question.
Yeah, sure.
Yeah. First of all, thank you very much, Stefan. It's really interesting to hear. So my question was, I was thinking about the same thing that you mentioned in your last sentence. You go more granular. I mean, apart from, the challenges that you mentioned, one of them is that the data set is growing short as you go in. In practice, what I do, like if I go and want to do, for example, some survival analysis with some subgroups, what happens is that I might find it that there's no event that I can do reliably, like survival analysis in my subgroups, or there are few of them, which makes my whole study in subgroups unrelevant. Is there any approach that we can potentially use so we can do analysis on subgroups while getting advantage of using old data? I'm not sure if
that's the idea of machine learning, because it can generalize a bit more than if you just do a traditional subgroup analysis. You would probably, of course, maybe filter for male patient 50, or 50 between 59. But of course, that would be like a traditional approach to like bucketing or really segmenting the patient cohort. Whereas in machine learning would generalize a bit. So it would can learn a bit like from patients aged 60 as well. And that helps in the predictions sometimes. So that's kind of the idea of machine learning. It does not work you still have one model that you fit, and then you analyze it for subgroups. And because you still have always one model on all data, it can learn these things a bit more clever, and it has a bit of, hopefully extrapolates a bit extra and intrapolates there a bit in a more clever way.
Thank you. Yeah, that clarifies it. Thank you.
Just also a tiny addition with this contrast with the subgroup analysis, and that I think the traditional statistics sort of aims to find some significant findings, saying, oh, this subgroup, they have precisely this effect. But in our case, by doing such a extreme sort of subgroup analysis, so that we reach level of individual level, we don't have any more sort of any single prediction doesn't have any so large significance. So as in we might have very large confidence intervals, etc. But overall, if we say, even by doing sort of this sort of low significance predictions for every single patient, we still improve the care. For example, if we compare our personalizer algorithm with, it's very technical language, but
I think that's the hope with machine learning, is maybe you go not only one subgroup, but maybe you have like 2 or 3, well, maybe a hierarchy of like, first you not only split by male and female, but maybe you have breakdowns like more in a tree structure where you have like eventually like 10 subgroups, whereas normally you only compare like 2 or so. So I would not go, simply because of how stable the methods are, I think one should not go too far here in order to always be safe and valid with the inferences.
Okay,
As a rule of thumb.
Thank you. I think we have a couple more questions on the group, on the chat, sorry, but I think we'll leave that till the end in the interest of time.
But we can also do it now, but better now, and then we
okay, sure,
have the rest exactly on time, and then.
Sure. So thank you very much. Just a quick question, if I can. To my understanding, usually the subset are not known. What approach would you suggest? Sorry. To my understanding, usually the subset are not known. What approach would you suggest to discover these subgroups if we have a new problem at hand?
Should I?
Valentyn, do it.
Yeah, this is right.
No, this is very, very interesting question. There is, unfortunate answer is there is no automated way to choose covariates. So there has to be a sort of an expert knowledge or some prior knowledge saying, for example, we need to know that those the covariates we want to do personally with respect to which we want to do the individualization, they have to be like pre-treatment covariates, because if we by accident add something which is post-treatment, we might be way better, way more accurate with predicting the outcome, but then we sort of immediately lose this causal interpretation, and what we will be sort of predicting only associational.
Yeah, I think the question is differently. Can we find like predictive biomarkers? And there are some layers on top that help you find subgroups that respond very positively to treatments, so that we can move from prognostic biomarkers to predictive biomarkers. And for example, the group by Mihaela van der Schaar has a couple of papers on that. So they helped find you like segments where you have a very positive or negative treatment effect.
Thank you.
But then, okay, then there was a reference to one of the causal graphs, but okay. Did we answer your question?
Darwin, if you're online, did that answer your question? Brilliant. He said yes, thank you.
Okay. Shall we go on?
Yeah, please. Thank you, Valentyn.
Yeah. So with just like 2 words on the previous slide, there are fundamentally 2 ways to formulate the assumptions, because we have seen from this slide with the causal hierarchy, like first ladder of causation, we saw that you cannot simply take the data from observational layer and then do the inference on interventional layer. In general, it does not generalize this way. So we need some mathematical assumptions, and there is whole 50 years of econometric studies which offered this potential outcomes framework, and there we sort of have a very general but also very abstract assumptions. On the same way, there was a more like computer scientist approach with structural causal models from Pearl or Barenboim, and there the main way to think about how to make assumptions is to imagine a causal diagram, which sort of incorporates our structural knowledge about the world, about the mechanisms in our body and what interacts with what, etc. But at the end, both sort of frameworks, they were shown to be equivalent, and they end up we end up employing the same methods. Like once we did those assumptions, we say, okay, fine, now we proceed with estimation. But it's also important sort of think in both frameworks. So here is an example where we say we want to estimate the heterogeneous treatment effect of the development aid on the sustainable development goals in different countries. And we say that if a treatment is some certain amount of money spent for development aid for a certain country, and the outcome is the HIV rate in this country, then we might sort of gather the data. We would be thinking on a high level, or what sort of causal graph would correspond to this data. We would say, oh, those covariates are pre-treatment covariates, so they could potentially cause both treatment and outcome. That's why it would be very wise to include them. At the end, we would need to speculate a little bit, because how we can never sort of check this without randomized control trial data. But for now, that's how the majority of those real world studies are done. Then we sort of choose the causal quantity of interest. For example, in this case, it's going to be the conditional average potential outcome. And we also sort of formulate our assumptions. Those are, I mean, I don't have that much time to talk about them, but essentially we say that first, the consistency that potential outcomes are sometimes observed in our data. Second assumption is that positivity means that every sort of unit of observation has a chance to receive or not receive a treatment. So we never have a sort of population, a part of the population who will never get a treatment. So we need this conditional randomization. And the last assumption, here it's formulated in a very technical language, but essentially it says there is no unmeasured confounding. So we sort of, if there are confounders, they are included inside of this X covariates. May go to next slide. And going to the second part where we talk about what sort of methods we can use. Still, even with our assumptions, when we know, okay, if we have infinite amount of data, we can estimate all of our causal treatment effects. Still, with when you only have finite amount of data, which is usually the case, there is this sort of causal machine learning is still different from traditional one. So, for example, there are you can think of this example where you have two-dimensional covariate space, and then some like scatter points. Those are treated people, and some are not treated. And the challenge number one is next slide. The selection bias. So you could see that, for example, if you want to estimate the sort of potential outcome after being not treated, we don't have this transparent blue points. So for those who were actually treated, we don't know what happened to them. So we cannot really, I mean, in regular machine learning, we would have the X, we would have the Y, but we don't have a missing data. Here we have missing data. And then it might be the case that some parts of the space are, how to say, systematically missing treatment. Some parts of the space are systematically missing control units. And the next slide was the fundamental problem for Kate estimation. When we really want to know the difference, we sort of miss, we don't have any of, like, every single unit doesn't have a full information. So we cannot even know the difference. And that's why the whole sort of learning, statistical learning problem is not formulated like traditionally. And there are corresponding open problems. First, how do we effectively address the selection bias? Do we do reweighting? should we do something with the loss? Should we use should we stack some models, etc.? So this sort of question. And another open problem is that how do we incorporate inductive biases? For example, how can we regularize Kate or conditional average or KPO models? Like a regular inductive bias would be that, well, we recorded so many covariates, we think some of them might be actually confounders, but we don't know exactly what and how strong are those confounders. So the actual treatment, like actual heterogeneity, could be very low. So we really want to, like, how to say, regularize our Kate model, but at the same time, the potential outcomes themselves, or conditional average potential outcomes, would be very complicated functions. So that's also the question: how can we incorporate those inductive biases in our models? And then next slide. I think the development of those causal machine learning methods for treatment effect estimation really only started in 2016. If we look down at the causal trees and causal forests, those are very like one of the most classical treatment effect estimators. And but in general, there are two large groups for models estimating treatment effects. So first is the meta-learners. Those are methods where you can essentially take any machine learning, for example, regression or classification machine learning that you want, and then you just assemble those models in a right way. So you have this sort of meta algorithm how to assemble different submodels, and then those meta learners, they provide like a model agnostic guarantees of how well you learned your ground truth Kate. And there are also model-based learners. So we say we fix the special model class, and then we find special tweaks or tricks. How can we make it better tuned to estimate Kate? Not just it's not just a traditional machine learning. We sort of tweak it a little bit, or change something, or modify the loss, or also combine everything. But main thing that it's end to end. For example, yeah, as I already said, the examples with the special adaptation of the trees or forests. There are also like a whole stream of literature on the representation learning and deep learning methods as in model-based learners. If you can go to the next slide. Yeah, switching back to meta learners. There's also a whole stream which adapts neural networks as an instantiation for meta learners. And there are in general two subclasses of meta learners: the one-stage learners, where we simply fit one or two models, so S learner and T learner correspondingly, and then we use it as our Kate predictor. There are also two-stage solutions where we sort of infer those pseudo outcomes. Those are basically the surrogates for our Kate, and then we regress. We build a sort of second model where we regress our pseudo outcomes on all the other covariates. And examples are doubly robust learner, DR learner, or it's called, I think it's called residualized learner, R learner. Well, there's a question in the chat, I see. Do you recommend any algorithms? Then relax non-observer confounding by allowing observe. Yes, we will have a extension about that in a moment.
Yes, sorry, Valentyn. Can we also have one question from Nasir quickly?
Yeah.
Just a quick one. How do you see the role of synthetic data data that could be simulated perhaps in various different circumstances or various different subgroups. How do you see the role of that in the context of causal machine learning?
I think the connection has yet to be studied.
It's a very interesting question. I think, I mean, if you say I have access to real data and synthetic data, then I would always say we prefer real data, because you know, if you feed synthetic data generator or you have additional synthetic data, you essentially stay on this level layer 1. You don't really go further from that, whatever you do, without also assumptions. But if you, I mean, there might be use cases when you say, oh, we cannot really share the data, so we share this like private synthetic. Yeah, those are those are extensions yet to be sort of studied rigorously. Yeah.
The simple answer is we still don't have synthetic data generators for treatment effect estimation. All of the synthetic data generators that I have seen are designed for risk scoring, but not for treatment effect estimation. But I can also spoiler that I heard about some working papers in that area.
Okay, thank you.
Thank you very much.
But the problem is that, again, if you use existing synthetic data, it was generated in the ladder 1 way and not in the interventional way, ladder 2 from Pearl's causality ladder, and that's why it's it's not really effective.
No, that makes sense. Thank you.
You want to wrap up a bit, Valentyn?
Yeah, I think
that we have enough time.
How exact are we with the time violation?
So it's coming up to 3 o'clock now. I know we've asked quite a lot of questions throughout, so I know it's sort of causing us to run.
We should take questions, maybe.
Yeah. Okay. Then
next like 5 minutes or so. Right.
Essentially, there is that's the overall like table to choose the methods. Overall, and if you go further to the slide with the extensions.
Let's see.
No, next one. Yeah, this one.
Yeah,
this one.
I would. That's too technical. I would not go into.
No. I just touched because there was a question in the chat for no unobserved confounding. There are extensions when we say, oh well, hidden confounding is violated. And then there's a whole sort of stream of literature called sensitivity models when we say, well, we allow for a little bit of confounding, and then we sort of have not the point prediction of the gate, but sort of like upper and lower bound, which could still be useful.
Yeah, those methods are also like very traditionally rooted in epidemiology, but we can extend them sort of like now to also causal machine learning. They work in a very similar way. So we get like not the traditional uncertainty interval, but we get bounds on the treatment effect, how large it could be. So we can run some kind of like sensitivity checks. Of course, that those are not perfect, but they help us to understand whether there maybe is a significant source of unobserved confounding.
Thank you, Fires. Does that answer your question from the chat? Yes, he said it does. Thank you.
they said some things. Okay. Overall, yeah, just to wrap up the whole, because this in many cases it like this whole sort of causal machine learning, it looks, because we use the same methods, I mean, or like fundamentally the toolbox is like the same. We still have like neural networks, we still have forests, etc. We still have the question of like regularization. We have a like bias variance trade-off. The problems of the traditional machine learning are the same, but now we have additional tasks of like, oh, how do we validate our models? What if we violate the causal assumptions? How do we also deal with the extensions? Gets very tricky with like time varying treatment effects. Can we also fuse the data from multiple environments? There was also a question on like, oh, but like, what if we use synthetic data? Also, what if we want interpret, like how do we, for example, how do we design like two-stage interpretable learners, or even explainable ones? How do we enforce privacy, and then can we still estimate treatment effects? Also, like the traditional question about uncertainty. What if we just simply have too little data and too large neural network, and then it overfits? How do we know? And those are all the challenges which are partially solved or not solved at all. And yeah, our group sort of works on all of those. Well, some of those directions. Yes.
Now is a good time to ask like the wrap-up questions.
Fantastic. Well, thank you very much for a really interesting talk then. So yes, does anyone in the room have any final questions? Excuse me. Have any final questions to finish off the seminar?
I can ask another question.
Yeah, of course you can, sir.
So thank you very much again for the great interest. I'll definitely visit back this paper. So first of all, is there a tool, you mentioned a tool during your talk, so is there like a toolbox, hey, what's that on here? GitHub toolbox that we can explore a bit?
There are two packages which are very common or prominent nowadays. One is the do-why package. By the way, both are in Python typically. The second one is called Econ ML. And I can also write the names quickly in the chat.
That's great, thank you. And just another quick question. I mean, this is follow-up of my question from the my previous question. So imagine when you want to investigate the, the outcome of the model for a subset, right? So you want to benefit from the whole set and do analysis on a subset. Which of these methods, because you had a slide also that was really nicely showing which method to select in which scenario, but imagine a scenario that the subset that you're looking for is the minority. So that's usually the case. And at least in my experience with machine learning is that they tend to fit toward the majority of the data. If you have a subset that is in the minority, how would you go about that?
I think it's a challenge, but as you said, like with all machine learning. And before Valentyn can add on it, I want to highlight one or two things. That it's first of all is challenging, and I think normally we have some tools where we do some rating or so that the method also puts enough attention on the minority group. Some methods for causal machine learning still here would need to be developed, and that's one point. And Valentyn, I guess you want to go on the overlap violations here.
Yeah, that's very actually related. That's a very nice question. Also, I think the sort of two-step learners would be more like a solution, because you say, I want to fit this sort of Kate model, which works the best for this minority. I don't really care that much about everybody else, but more like this minority. And then we could really talk about for example, difference between the R learner and R learner is that the R learner sort of tries to learn the Kate for like all the space equally well, but R learner sort of learn it really good only for the patients, like for the parts of the space where we have overlap. So we say we only care about the covariates, the values of covariates where we are sort of uncertain about treatment estimation. Though that's why there are treated people in this subgroup and also untreated, and that's because like practitioners, they didn't know what to do, so that's why they actually help to randomize this thing. But then in the parts of the space where we are actually very sure, we say like, oh, this is a like severely ill person, we would give way higher dosage there. Then we don't really need sort of counterfactual data point there. And but those are actually the points where we are very certain about treatment. those are actually the parts of the space where it's the hardest to estimate the treatment effect. But the answer is yes, we can we would need to formulate our weighted loss. We say like we need to really upweight this sort of minority, and then we can. There's a very I can share the like a sort of technical paper on that, where sort of any like a very large class of weighting functions works, and then anyone could like derive their own sort of learner for that.
Yeah, thank you. I appreciate that.
That'd be brilliant. Thank you. I think because we're coming really well, because we're a bit over now. Unless anyone's got any last burning questions, we'll call the seminar to a close. But thank you very much, Stefan, and thank you very much, Valentyn, for a really interesting talk. And it's been really interesting. I've certainly learned a lot, and I'm sure you'll probably get lots of emails from people in our group asking further questions. So, but no, thank you very much to both of you, and best of luck with your future work. And
thank you.
And thank you for everyone online and in person for attending. And see everyone next week.
Thank you.
Thank you.
Bye.
Bye-bye.